So the multi-omic integration, curated rare variant repository, and then again, the previous speaker was talking about this point very significantly, the secure and scalable infrastructure. So all this data, we need to have complete security and secure infrastructure where it can be analyzed and integrated. So how we are doing it? So the first step is most critical step where we are gathering all the information which is already published in terms of the information about the gene, the disease, the pathway. So you identify with the condition. Okay, I want to identify one loss of function variant, which is for hypertriglyceridemia. So you understand the genes, you go for large reasoning models, you identify the function of the genes, which are the genes involved in the pathway of complete triglyceride function, and then you put in the impact factors, the PRISM factors into it, and then you look at the journal database, which one has the highest impact factor, which one is meta-analysis, which one is a randomized control trial, which one is so on, and each one is scored in a way which is an machine learning model that we developed, and then it gives the importance of the gene associated with hypertriglyceridemia in the pattern of importance. So we have almost 22 to 23,000 genes. Out of that, the top 200, 300 genes which are directly involved will be listed. And then comes the second part of it, which is this is little bit more happening slide, but so ideally what it does is, so each one we have to look at each and every ethnicity. So that is very important for any pharma company to identify. Is it going to work in one ethnicity, not other ethnicity? So we look at we have a variant, we have a condition, we have a gene. Okay, what is the minor allele frequency in this population? If it is very low and rare, okay, is the guy protected or not? We divide into cases and controls in this matter, and then run it through this algorithm, which says that most likely this variant might be protective in this case. So once we have that kind of an information, then we again go back and validate in the global literature. Is it protective? What are the genomic data information available? You go into large databases like All of Us or UK Biobank, and then validate, okay, this is the loss of function variant which is present in this gene, and people having this variant have very less triglyceride levels. People not having this variant, or who are wild type for this variant, are having the disease. If you can evaluate, again, the strength of the disease depend on the N, and the statistical significance depends, the p-value depends on the number of people that we enroll. But once we have that data, that is when the most likely treatments can happen, because gene editing is not allowed, or it is within not the ethical and legal basis, but gene silencing is. So the gene silencing through either small siRNA or ANA anti-nuclear antibody is possible. But this is where most of the treatments for chronic non-communicable diseases are happening. And this database, whenever we are doing a long-term genomic analysis, this database is of critical importance in deciphering these variants and possible drug discoveries in future. So this is from variant annotation to target drug discovery. Again, the variant functional scoring, the AI model predicts, and alpha missense is again by Google, and then primate AI is from a different private company. You run this algorithm through these models, and it will potentially predictively give you that this might be an target for taking further analysis. And then again, network and pathway mapping, which is graph learning basis and continuous learning framework. So again, summarizing the whole thing, so the protective loss of function signature identification will become priority, especially if you can have an phenotypic correlation, allele frequency, predicted impact, and disease modulation impact. And then functional and clinical filters. This is where the phenotypic penetration filters are present. And this requires a huge database. We are currently having about 10,000 patient data, but ideally it should be at least in multiple tens of thousand data to validate one variant. And then these are the focus of interest for us right now for the gene and the condition. So there is a KDR gene, which is VGFR, which one present will cause very aggressive kind of glioma. We are trying to find out protective variants in KDR, which will slow down the progression of glioma if we can find inhibitor. Same as with monogenic diabetes and hypertriglyceridemia, we are looking for two variants in MTTP, and Parkinson's disease LRRK2, which is again very difficult to predict because the number of Parkinson's is still less. So triglyceridemia, glioma, and monogenic diabetes, we are aggressively moving forward with possibility. So again, coming back to the final statement. So AI and explainability on target validation. So we need to have proper database structure so that the predictions are transparent and biologically plausible. And then there will be a human and AI collaboration eventually, because that is where most of the things will happen. So this is my talk. I will leave 2 minutes for any questions or any comments. Once again, I'm Dr. Kaljana Palluri, founder of GenePower RX, precision diagnostic company.